Yeah, so thank you for this whole educational program. Dr. Rajiv sir has done a wonderful program, and this we are reaching the fag end of that with retina. So I'll be talking about ultrasonography. It is a rapid, non-invasive imaging method and evaluation of anatomy of the eye, and media clarity or haziness do not affect it. So it is a two-dimensional brightness display where the strength of the returning echo is basically displayed on as a dot on the screen, and those dots are joined together to form the ultrasonography. So these are the properties of sound waves. It has a wavelength, it has a frequency, amplitude, and velocity. And what we are doing is the production of ultrasound is by piezoelectric crystals, and that sound waves are being sent inside the ocular tissue, and then the echo which is generated from those tissues are brought out, and the images are amplified. So just telling, these are piezoelectric crystals, and high frequency sound waves are transmitted from a probe into the eye. Sound waves strike the intraocular surface, and each surface has a different reflectance, and those reflectance are converted into electrical signals and amplified. So where is an ultrasound indicated? Whenever there is difficult direct visualization of intraocular structures. We all know that, unlike all the other structures in the human body, eye is completely transparent. Most parts of the eye are visible through a very transparent cornea, anterior chamber, lens, and vitreous. So majority of the optic nerve, the retina, all those are seen very clearly. Only very peripheral places like the ciliary body area is a little difficult to see. So if there are significant lid edema and torsal tarsorrhaphy, you cannot open it up. Corneal opacity like scars or severe edema, you are not able to see it. Hyphema, hypopyon, or pupillary fibrin, or vitritis, which is dense, or any of those things, dense cataract through which you cannot see the posterior segment, or vitreous opacities, you will do an ultrasound. The frequency of the ultrasound that we use for abdomen is about 2 megahertz. For posterior segment is about 10 megahertz, and for ultrasound biomicroscopy use for 50 to 100 megahertz. Higher the frequency, lesser is the penetration, and greater will be the resolution. That is how the frequency of an ocular ultrasound is somewhere around 800 microns, whereas that of a UBM is about 50 microns. Amplification of the display can be done by adjusting the gain. Low gain means increased resolution. The resolution power is much higher. High gain means there will be a lot of grains, but it will pick up even smaller problems. So there is increased sensitivity. And that is how we do an ultrasonography. There are different probe positions like transverse, longitudinal, axial, and there is a mark on the upper part of the probe, and where that mark is there, we will see it on the ultrasound as the uppermost part. That's a very important thing whenever you want to actually make a position of the ultrasound. Now, a normal ultrasound is looking like this. I'll just show you some of the normal lens. Is seen as an oval high reflective structure with intralesional echoes. Okay, so now this is a lens. The second picture here shows the lens. This is the posterior capsule. This is almost a clear lens. Whereas as the lenticular, intrasubstance, the echo increases, that means there is more of a cataract. And sometimes there can be reverberations behind it when you have a pseudophakia. Vitreous is usually acoustically clear, but can show low reflective echoes depending upon the amount of syneresis. Like, for example, these are some PVD, something like this. These are normal in older people, or in myopes also post 35 years, 40 years, you can see a lot of PVDs like this, and thickness can completely be different. And retina, choroid, and sclera are seen as a single high reflective structure unless there is a problem in it. And optic nerve is a wedge-shaped acoustic void in the retrobulbar region. So you can see this is the optic nerve here, and you can see the cupping which is on the surface. Here is again an optic nerve, and the retina and the choroid, all those things are composite here. Now let us go into clinical uses of each of these areas. Vitreous, we can pick up vitreous hemorrhages, vitreous inflammation, other intravitreal echoes. Sometimes you may have to repeat the scans to see how things are changing. Now in vitreous hemorrhage, you can have without PVD, with PVD, subhyaloid hemorrhage, areas of attachment. These are very important. It is not just to pick up a vitreous hemorrhage. If you see the red blood cells in the retrolental area, or even during an indirect ophthalmoscopy, you are able to see blood. Your diagnosis of vitreous hemorrhage is done. But we do an ultrasound basically when we are going inside for a surgery, where to start inducing the PVD, where PVD is already there, where there is a tight adhesion. All these things have to be made out when you are going in for a surgery for a vitreous hemorrhage, and that is why an ultrasound is very important. Now, this initial picture is there. There are a lot of point-like echoes which are moderate to high in intensity, but you can see that there is no PVD. Whereas here you can see there is a clear space between the posterior hyaloid, and you can see that is a complete PVD. And within the PVD, we have vitreous echoes, mild to moderate echoes, point-like echoes. So that is with PVD and without PVD. Now there could be partial PVD as well, like many of these cases in which like diabetic vitreous hemorrhage, PVD is more difficult to come. Whereas the vascular block with neovascularizations with PVD, or age-related macular degeneration which can bleed, and subretinal hemorrhage breakthrough into the vitreous, all those can have PVD. Now you can see sometimes there can be partial PVD. You can see the attachment here, and it is attached to the disc. So this could be partial PVDs. And retrohyaloid hemorrhage is another important finding. So whenever there is a retrohyaloid hemorrhage, we understand that the vitreous is significantly lifted up from the retina. And so there is a space through which you can maneuver that posterior hyaloid, and the prognosis in such patients are extremely good. And so these are retrohyaloid hemorrhages, and you can find out the actual area of attachment. And then sometimes subretinal hemorrhage can come. This is an old person with vitreous hemorrhage here, but you can see that there is a subretinal hemorrhage also. The retina itself has lifted, and the density of the subretinal hemorrhage is usually much higher. So now there are some membranes in the vitreous. Dr. Papa, you can tell me when it is time. When about 2 minutes, you can please tell me. Membrane in the vitreous, which is PVD, RD, and choroidal detachment. So this is a normal PVD, as I told you. This is almost a total PVD. The important feature here is to do a dynamic ultrasonography. You are keeping the probe in one particular location, defining the PVD, and ask the patient to move here and there, and we will actually see the movement of the PVD. The movement of the PVD will be undulating and very slow movement in a PVD, whereas it will be rigid and flapping in the case of a retinal detachment. So this is a retinal detachment. So the difference between a PVD here and a retinal detachment here is that the retinal detachment is always attached to the disc when you are looking at the disc. If you are not looking at the disc, it can be sometimes completely separated. So you have to always look at the disc and see whether the thick membrane, which is very hyperechoic, is attached to the disc. Whereas a PVD is having much lesser echo texture, and even at high gains you will be able to see. At low gains it may disappear. A retinal detachment will never go away in a low gain. Even if you reduce the gain to significantly lower levels, the retinal detachment will be there. Then I talked about dynamic, the movement and the ultrasound. This is a very typical signature echography of a choroidal detachment. This is like two sides are joining together. If it is more, then it is called a kissing choroidal. Now, vitreous haze. Now, I want to tell you that the amount of vitreous hemorrhage and the amount of echoes may not always go hand in hand. It is very important in case of vitreous haze as well, in uveitis or endophthalmitis. Just because you did not get an echo on the ultrasound doesn't mean there is endophthalmitis. Or just because you got some echoes in the vitreous doesn't mean that there is endophthalmitis. It's both ways. It is very it's important to understand that, because normal PVD can also lead to echoes, and sometimes significant endophthalmitis may not lead to echoes, basically because the tightness of the structure, the vitreal structure, actually gives rise to the medium-shaped echoes. So this is like a endophthalmitis. In which, so usually in a endophthalmitis or vitreous haze, it will be similar to a vitreous hemorrhage. It's extremely difficult to differentiate between a vitreous haze on the one hand and vitreous hemorrhage on the other hand. Vitreous hemorrhage will have will have red blood cells retrolentally, and vitreous haze will have white blood cells behind the lens. Now, vitreous haze, it's important to do serial scans to look at evolution of PED and evolution of VR pathology. Sometimes you can have dislocated lens into the vitreous. You can see this is a lens which is dislocated into the vitreous. Any other material can also, so sometimes there can be a dislocated lens, like this is a lens which is dislocated. You can see that the posterior capsule is moved a little back, and this could be either some other foreign body, or it could be probably a lens matter. If it is a metallic foreign body, you would usually see a shadowing here. This is not a metallic foreign body, is what I would understand. And in retinal detachment, I told you something about retinal detachment. So retina is always attached to a disc and will have very high echo density. There are some exceptions, like a giant retinal tear which is completely loose, and a large tear which is completely detached. Sometimes you may not be able to actually find out the disc, and there will be multiple layers of the membranes there. So this is in a very low gain, and even in very low gain, the retinal detachment is seen. Sometimes it can be very high and thick, like in a PVR. This is a PVR. So posterior PVR is there. Probably this we would see as an open funnel, and this we would see as a closed funnel. You can see that this opening up of this particular thing is closed here. So this is a closed funnel. Sometimes there could be retinal detachment along with vitreous hemorrhage, either that there is a tear occurred on the surface of the retina while the tear was coming, or there could be a traumatic retinal detachment with vitreous hemorrhage, etc. Tractional retinal detachment always has some element of traction, and there could be combined secondary rhegmatogenous retinal detachment or pure tractional retinal detachment. You can see that there will be multiple vitreous echoes which is pulling, and the pulling has to be made clear, and the mobility of these retinal detachments won't be there like a rhegmatogenous retinal detachment. A rhegmatogenous retinal detachment is mobile, like a flapping. A PVD is significantly mobile and very slowly mobile, whereas a traction retinal detachment wouldn't move. But the area of traction and the pull on the retina and the deformity of the surface of the retina will be seen. An exudative retinal detachment will show up as, there will be shifting fluid. So if you move here or there, the fluid may shift from one side to the other, and there will be a causative factor for the exudative retinal detachment, like a tumor. You can pick up a tumor, you can pick up any other things like that. In a VKH with exudative retinal detachment, the thickness of the choroid will be significantly high, etc. So here you can see a tumor, or here also you can see a tumor with exudative retinal detachment. Okay, again, this is a retinal detachment with closed funnel. RD can take myriad forms. This is a cyst within a retinal detachment. You can see that this is not taken through the optic nerve. So any area of the eye can be imaged, and a myriad form can be produced because of that. Okay, so these are all, you can see here, the retina is slightly elevated. A shallow retinal detachment is there. Here it is a GRT which is crumpled down in one particular area. So some of these retinal detachments you can see clinically, and then you are just doing an ultrasound for an academic interest. But yes, you should do that so that in a white cataractous eye, you will be able to actually make out the different morphological features of the retinal detachment. Here is a retina which is right behind the lens. This will be very difficult when you're going inside. You'll always go into the subretinal space and cause problems. And this is an intraretinal cyst in a retinal detachment. Choroidal detachment, suprachoroidal bleed, suprachoroidal abscess, choroidal thickness, all these are very important. Like as I told you, this is a signature ultrasonography, a morphological marker of a choroidal detachment, wherein there are two from either side, there will be a compressive lesion like this. And these are massive kissing suprachoroidals. There is blood underneath the kissing choroidals also. Okay, so these are all different types of kissing choroidals. Now, choroidal thickening is seen in a lot of conditions, including endophthalmitis, including posterior uveitis or pan-uveitis, including posterior scleritis. But in posterior scleritis, it's very marked. It is called a T sign. Okay. Now, scleral rupture is a very important. Scleral or corneal rupture occurs, and you will not be able to, clinically examine because the view will be very hazy. So you should do a very soft ultrasound to make sure that there is no posterior scleral rupture, which is a very bad prognosis. Sometimes you can pick up staphyloma and so this is a posterior staphyloma. Can you see the U-shaped cavity here? That's a posterior staphyloma. This is a coloboma. And this is a scleral rupture. This is a posterior scleral rupture following a trauma. You can see that the prognosis is very poor whenever there is a posterior scleral rupture, because you'll not be able to approximate those. Uveitis, as I told you, vitreous haze is an important thing, disc edema, exudative retinal detachment, etc. So here is a disc edema. You can see the disc here, the optic nerve is here, the disc is here, disc is edematous. Okay. Now vitreous haze, as I said, there will be a lot of point-like echoes in the vitreous cavity. And definitely this is a cysticercus. There's a cyst with a scolex in the center. This is a cysticercus. And tumors, yes, it's very important. Detection of opaque media, as well as differentiation of tumors between tumors in a clear media, and also to understand the tumor size, the height, the base area, and whether the tumor is progressing or regressing with our treatment. So melanoma, metastatic cancer, hemangioma, retinoblastoma are some of the tumors. Malignant melanoma usually will have lower, intralesional reflectivity. There will be some acoustic hollowing, and so that will be seen in malignant melanoma, and it's usually a collar stud shaped lesion. Metastasis will have medium to high internal reflectivity, and it will be usually solitary, not multiple. And choroidal hemangioma will have high internal reflectivity. Choroidal hemangioma will be definitely having more reddish hue, whereas melanoma in most cases will have that pigmentary hue. Okay, retinoblastoma will definitely show calcification. So the other tumors may not show calcification. Retinoblastoma will definitely show calcification, and the age group is also different. Okay, sometimes you can pick up orbital tumors. If the frequency that we use is slightly lowered, you can penetrate into the orbit very clearly and see orbital tumors which are compressing the optic nerve. And tuberculoma, choroidal abscess, all these things can be made out. This is a case of osteoma. Osteoma is a very thick bone-like tumor in which you will look like you are seeing a double optic nerve. Like this is the normal optic nerve, and this is the osteoma with the subretinal fluid. And you can see here also there is an orbital shadowing because of the calcium within the osteoma. Optic nerve cupping, disc edema, disc drusen. So this is optic disc edema, which we showed. This is drusen of the optic nerve, which will also show up in an autofluorescence. This is a glaucomatous cupping. A very mild cupping can be seen here. And ultrasound can also help in color Doppler. You can see the blood flow through the ophthalmic artery. You can see the blood flow through the central retinal artery. And also you can see tumor circulation. So 3D ultrasound is also to do the tumor sizes. Thank you very much.